Thank you for joining me today. My name is Jennifer Geremia. I'm a physician assistant in gastroenterology, currently practicing in Boston, and I've been taking care of GI patients now for almost 18 years. And that includes our MASH and MASLD populations. And I'm happy to be here with you today to go over recent guidelines in identification and risk stratification for these patients. And really, I'd like to address today what are our PCP screening guidelines in identifying at-risk patients for MASH and MASLD. And it's great that we now actually have guidelines and treatment protocols based on what we find with identifying these at-risk patients. And really, these are folks that you're seeing day in and day out, and really has to be added to sort of your health maintenance check sheet. Often in this population, who needs to be screened? And those are patients with metabolic disorder. So type 2 diabetes with or without obesity, obesity by itself, or overweight patients, and sort of your classic metabolic syndrome patient. Hyperlipidemia, high trigs, prediabetes, insulin resistance, increased abdominal girth, hypertension. You are seeing these patients day in and day out. And this affects all across the spectrum, all specialties, and in particular, internal medicine specialties. And screening these patients, I liken to, health maintenance for diabetes includes things like an eye exam, a foot exam, kidney screening for diabetic kidney disease. But yet somehow the liver gets lost in the sauce, as I like to say. And so really adding liver to your check sheet for health maintenance patients. Patients are obese, you're checking LDLs. Like, we have that pre-ingrained in our protocols. And now we do need to add one more thing to that protocol when we see these patients. So based on these current guidelines, those are the most at-risk populations. Now, naturally, there could be folks that we incidentally identify steatosis. Perhaps they had some type of abdominal pain. Perhaps they had abnormal liver function tests and you went ahead and ordered an abdominal ultrasound. Maybe you did a CT scan for diverticulitis, whatever the case may be. And now we have this incidental finding of steatosis. So we sort of stumble upon this in various ways. And early in my career, nearly 20 years ago, I was in internal medicine. So I highly respect the challenges and work that you do, but you're the gatekeepers again for this process. And early on, we didn't have good guidelines. We didn't have good screening tools. We didn't have treatment. So we may have nod to the patient and say, hey, oh, by the way, your report said you had fatty liver, try to lose some weight, don't drink a lot of alcohol, but we were somewhat passive about the process. And so where do we go once we see this patient in front of us that has these risk factors, right? So by guidelines, by multiple governing bodies, so AASLD, our endocrinology colleagues tell us that we should start in the primary care space with FIB-4. And really, we know that there's limitations to FIB-4. I don't think that there's a question on that. But that is essentially an easy, practical calculation that you can do in most apps on your phone, or you can, if you in particular have Epic, you can create a dot phrase in your EMR that is going to look at age, AST, ALT, and platelet counts. Now, it may skew one way, too low, too high, based on some of those, but it is at least a starting point, and it is a validated starting point. You also can do the non-alcoholic fatty liver fibrosis score, which takes a couple of other numbers into account, including BMI. But looking at AASLD guidelines from our liver governing bodies, they tell us to start with FIB-4. And so your FIB-4 is going to give you 3 buckets, right? It's going to be low, indeterminate, and high. And indeterminate patients then need some follow-up testing, preferably in some form of elastography to get liver stiffness. If you either do not have access to that or access to getting someone into GI in an expeditious way, you can also order serum ELF testing through your local lab. So, but your starting point is going to be that FIB-4. And if they're low, you can recheck them in about a 2 to 3 year period. Now, if someone has an abnormal FIB-4, what does that sort of conversation look like with the patient? And I think the key is not to scare the patient, but also not be passive like we were many years ago, where we would just sort of like limit alcohol and try to lose some weight. You really need to let the patient know, look, in addition to treating your metabolic conditions and making sure that your blood sugar is under good control, making sure that you're getting adequate exercise and appropriate diet interventions, making sure that we know, again, we do everything on the check sheet. If we don't address this and monitor this, you potentially can be at risk for developing fibrosis and ultimately cirrhosis. And as we know, cirrhosis is the highest causation of liver disease for transplant in women and second all cause. So has replaced Hep C because we can cure that and is on the rise. So it can be fairly significant. And the word cirrhosis is scary to patients, right? They kind of get the deer in headlights. But I think we need to speak to that, right? They need to understand what the risks are, just like you could tell them with diabetes, you can lose your vision, you could lose your feet, right? So there's consequences if we don't address this. And so again, if this FIB4 is relatively low, their liver functions are otherwise normal, then the impetus is just to continue to aggressively treat their comorbid metabolic conditions, having a discussion about lifestyle, potentially referring to nutrition, and impetus for activity. I like the word activity versus exercise. And about 150 minutes per week. And ideally, you want about a 7 to 10% total weight loss for this to be meaningful to reduce steatosis and potential associated fibrosis. If someone is, again, in that indeterminate bucket or certainly high in terms of their FIB4 score, you want to go ahead and refer them out to GI for additional, whether that be second line testing, treatment, etc. But I think the take home here is go ahead and add these screening tools as part of your health maintenance check sheet for these patients and have an honest conversation with the patients. The other thing also is doesn't mean they can never have alcohol. So it's about 20 grams per day for females and 30 for men. So sometimes, and patients will ask you questions like, can I still take Tylenol? Yes, within the recommended dose on the bottle, right? So practical applications and conversations that happen with these patients. I can appreciate, like I said, I know you guys have a lot on your plate in the PCP world, and it's just one more thing, one more challenge in terms of having to worry about. But the problem is that MASH is quiescent. It doesn't cause symptoms apart from potentially some maybe abnormal LFTs in some folks. But otherwise, by the time they have symptoms, that means they have end-stage liver disease. They're presenting with ascites. They're presenting with esophageal viral bleed. They have low platelets because they're starting to develop decompensation and portal hypertension, right? So there is no presenting symptom. So that is the nefarious part. And also that's also challenging for patients because they don't per se feel anything from it. So how do you get buy-in? I really think the easiest way to approach this when you see the patients that fit an at-risk population is to do FIB4. I'm not even necessarily saying that you have to burden yourself with trying to seek out a FibroScan in your area. Although if you're practicing here in the Northeast, it is fairly readily available, but that doesn't mean that it's in your office. And it doesn't mean that you can get it tomorrow, but a lot of outpatient radiology facilities and most hospitals and even GI clinics may have it. But then again, just start with the FIB4. If it's low, then you've done your due diligence. I recommend yearly. The guidelines say every 2 to 3. I mean, I think, these risk factors are there day in and day out. So this nominal calculation that uses labs that you're already doing every single day. So you're doing CBCs, which have a platelet. You're doing CMPs, which have AST, ALT. You know their age, right? So you're not really doing any additional tests at this point. So I really think in a primary care setting, FIB4 is the starting point. And if you're like, oh, I need to stop here, right? I'm not comfortable getting FibroScans or ELF tests. That's okay. Refer out. And then if there seems to be, okay, there's nothing for us to do here, just continue sort of modifications and manage your comorbid conditions. Maybe then that patient gets sent back to you. And if there is something to treat, then you've referred them out. So I think those validated exams are reasonable. And I think the other piece of this, though, is if you do have patients with abnormal LFTs, they deserve a workup irregardless of what their FIB4 is, right? So if you have persistently elevated alkaline phosphatase, if you have transaminases that seem to be fluctuating, if you have persistent elevations in transaminases, again, I'm not implying you have to do the workup, but those folks really should be referred out, even if their FIB4 is normal. If you've done an ultrasound and it says fatty liver, yeah, perhaps it is all related to MASH, but we do need to do our due diligence and make sure that there's no other causation or concomitant liver disease for these folks. So I hope this was helpful in identifying at-risk patients within the PCP realm so that we can together identify and treat this challenging population. Thank you for joining today.